forward to the computer. We're going to share the screen. We're going to grab that PowerPoint. And you're like, he's talking to himself again, so he doesn't forget anything. That's great. He's getting old. 19, chapter 19. All right, so this is, you know, when we went through all the other chapters and you were like, why do I need to know all this stuff about the immune system? It's because you need to know something about how the diseases deficiencies show themselves. And when we talk about classifying those and testing for those. So we got some testing at the end here. So that will be in your wheelhouse to do. So we're going to talk about primary versus secondary immunodeficiencies. Most of the ones we're going to talk about today are primary. Immunological defects, what's wrong, and what your book will tell you is most of these are combinations. So you've got more than one system being in the process of a problem. So we'll go over that. It's not just one thing. One thing can lead to the other. The other can lead to this. And we know that because we've gone through the whole immunoresponses, whether it be the cellular immune response or whether it's the humoral. So disorders in which part of the immune system is missing. So decreased ability. So these are how we classify. So the immunodeficiencies are disorders in where part of the immune system is goofed up, whether it's gone, whether you weren't born with it, or whether it's just dysfunctional. We have decreased ability to now defend against infections, so we're more susceptible, even to the point of developing cancer. Primary immunodeficiencies, these are inherited. So these are ones you're born with. So that's what we're going to spend most of our time dealing with today. They can be X-linked. Okay, so what is X-linked? Who's my geneticist? Who's taken that DNA, RNA lecture and gone all the way into becoming an expert on genetics? Who's had a genetics class? Maybe I should start there. Anybody on Zoom had a genetics class? Sometimes, how you need to pick up an elective and you took a genetics class? Nobody? So what does X mean? Let's start there. What does X mean? When we talk chromosomes, what's X mean?
Female. Female.
Female if it's 2, right? But males have an X too. Males have 1 X and have a Y. Females have 2 X. Okay, so if it's X-linked, that means that females, since you have 2 X's, probably are going to be okay. One of your parents had a bad X and the other one didn't have a bad X, and your good X is overshadowing the bad X. So these are male. The male gets a bad X, there's no other X to help out. So they have a Y next to it. So these are usually male patients. They're called X-linked disorders. What's autosomal recessive? Recessive, right? It's the little letters, right? We're always little letters when we're talking recessives. This means you don't have a big letter. So this means if you're autosomal recessive, means your parents gave you the little letter for both of these, and you don't have a big letter to change things from your other parent, so you end up with it. So we can say, just take, carrier. Carrier is usually somebody that has a little letter in the gene chromosome and a big, right? And they gave their child the little one. If you get 2 parents who both give you the little one, that's where the recessive comes in, and that can be why you have the disorder. You ended up, like when we think of that, I always think of cystic fibrosis, right? We think of that as you can be a carrier and not know it, right? And you marry another carrier and you have a child, and all of a sudden you've given your kids cystic fibrosis because you both were recessive carriers of it. Does that ring a bell? Maybe how that works. Autosomal dominant, right? You can also have it being just because it's on the big allele, the big dominant number, and it can be because you inherited that instead of the recessive. So we have that. Secondary immunodeficiencies, These are acquired as a result of another condition. This would be, you know, our great example here is HIV. You become infected with a virus that causes you to start losing some of your immune system. So that's a secondary response. So this is not something you're born with. Autoimmune disease are secondary. Malignancies are secondary. Immunosuppressive therapy definitely would be secondary because you wouldn't be suffering unless you were taking that drug to suppress or that steroid to suppress your immune system. So those are the first things we kind of need to at least get an idea of why we call them what we call them. So immune system components affected by the primary immunodeficiency diseases, that's PIDs. That's not pelvic inflammatory, that's primary immunodeficiency disease, okay? Humoral immunity, the one we start off with, right, is predominantly an antibody deficiency, okay, is number 3. And if you look on 329, that's why the first one we talk about is category 3. And these have been categorized. And not so long ago, I know some of you think sometimes our dates go way back, but this is 2014 that we got this new update on categorizing the immune deficiencies into categories. So that's only 6 years ago. That seems kind of current when we think about some of our other stuff that we date. And category number 3 is the antibody deficiencies, predominantly antibody deficiencies, humoral immunity. And this would be the most prevalent. So it's 50% of all cases are in category 3. So that's why your chapter goes right into category 3 to talk about, because this is mostly half of all the ones we know that are in this category. So what is affected? We got humoral immunity, that'd be our antibodies. So it's caused by defects in B cells or T helper cells. And the patient with humoral immunity, this is the key. This is like basic immunology. I think you got this already, but test questions will keep popping up every now and then about if I have something wrong with my humoral immunity, what is the patient going to show? What is the patient going to present with? What is the patient going to come in and say, I just can't kick this. I'm always getting these infections, or I'm always getting this. And with humoral immunity, it's going to be bacterial infections. Okay? So you see sinusitis and otitis media, ear infection. So the patient seems to always have some kind of bacterial infection going on. And we can go, well, do they have an immune deficiency, right? So this would be showing early. This is not that 75-year-old diabetic patient that can't get rid of a lower leg infection because they're diabetic. It would be a secondary, right? This is the child that keeps coming back with some kind of lower limb infection, or always has ear infection, always has a runny nose, always has something going on with them. And that's where we can start looking at their humoral immunity and running tests to see that. Okay, we also have cell-mediated immunity. Involves T cell deficiency. So if it's T cells, then our patient becomes susceptible to viruses, fungal infections, and some bacterial infections, and cancer. Okay, so we've already learned about our T cells. We know what they can do. We know how they protect us from all this. They know why, this is why we learned it first, right? It's why the book's set up the way it is, because you were getting into the first 6 chapters, 7 chapters, whatever it was, can't remember the number. Before we get to chapter 19 to talk about this, you understand when we knock out T cells, what happens, right? And then we have the innate immunity, the ones we're born with. So this would be our neutrophils, our macrophages. These are the cells that protect us without having to be stimulated. They don't have to have any signals. They don't have to be programmed to go after the antigen. So if our neutrophils are decreased, our macrophages are decreased, of course we're going to get more bacterial infections. Our complement, we went through that. We know all the different levels of complement that can be decreased. There'd be a deficiency in C3, what happens, right? Bacterial infections, autoimmunity. So we're getting ready. We're right on the edge of doing autoimmunes, okay? I don't know if you are feeling that. But we're trying to get as much in right now before we get to the autoimmunes as we can, because we're going to spend some time in autoimmunity. That's kind of where your career is going to probably be focused a little more than mine. Was that we know more about them, we're going to be doing more with them, and you're going to be screening more patients for them. And hopefully that'll be what the doctors want to do. So here's a big chart. This is a big busy chart. This is the primary immunodeficiencies and their effects on the white blood cell function. So we got a big page. This is on page 328 in the text. It's got a key, so you don't have to look at me weird when I ask you what all these abbreviations stand for. You have them now. All right, you got a whole big list. And you got some of the syndromes up here. I see Weisskopf, Aldrich up there. We're going to talk about that. We got severe combined immunodeficiency. That's a big one. That's a fun one because we have a movie that talks about that. We got DeGeorge up here. Okay, so we see Bruton's. We see Shadiak-Higassi syndrome. We have that one. So these are the names you're going to need to be familiar with and start to put into some memory bank so you can answer questions about them. Well, real busy here. It's a really good summary. Okay, so you can just pick out where you want to talk about. We've got natural killer cell. We've got some plasma cells down here that can be effective, so we don't get the IgM, we don't get the IgG, we don't get the IgA. Here's IgE over here. Remember that? You know that picture? We don't have to have that labeled. We know that one. We've seen it just last chapter with our hypersensitivity reaction. We got our T helper. We got our cytotoxic. Any others on there? Look at it. Let's see. And we see where the block comes in or where the break is. So this is kind of like, okay, we've got BTK, that's Bruton's, tyrosine kinase deficiency, coming in right here and cutting off the development. Okay, so then we don't get any of this below it. So we see that. So this is kind of summarized. So when you get ready to study for the exam, go back to this chart, see if you can pick out most of everything that you've been supposed to know and where they fall in. So we have 9 categories. Here this was again done in 2014 for us. So we have number 1 is combined immunodeficiencies. Number 2 is combined immunodeficiencies with associated or syndromic features. 3, that's the one that's 50% or more, predominantly antibody deficiencies. Number 4 is diseases of immune dysregulation. So there's a problem with regulating it. Congenital defects with our phagocyte number, function, or both. Defect of the natural immunities, number 6, innate. Autoinflammatory disorders, 7. Complement, number 8. And phenocopies of the primary immunodeficiencies, the number 9. So luckily, we're going to spend most of our time in number 3 today. For you, there's more detail in number 3. There's a lot more names in number 3. And then we'll go back to number 1 with the combined immunodeficiencies, and we'll continue from there. So we start with number 3, which is predominantly an antibody deficiency. So these are low levels of our immunoglobulins, or agammaglobulinemia. Okay, should be a name y'all heard in histology already, hopefully. Hopefully you can make that name out. But if not, there it is, A gamma. So we got a decrease in our gamma globulins. So we got a decrease in our immunoglobulins. And it involves genetic defects in the B cell maturation. So B cells don't mature, or a defective interaction between the B and the T cell. It may involve all the immunoglobulin types, okay, or just one. So we have that. It could be all of them being affected, or just one or the other. So we're going to compare the patient's immunoglobulin levels with the age match reference range. So you have that, right? And I think it's a good little check, because we know what. So you look at this. This is Evaluating, it kind of starts on page 329, then you switch over. So the blood level of IgG at birth is about the same as the adult level, okay? Reflecting what? Transfer of maternal IgGs to the baby. So we have that at birth. So if we wanted to check IgG at birth, probably wouldn't be a good time, right? Because mom's got that taken care of, right? We'd want to wait until that declines. So it declines in the first 6 months. So usually babies are healthy and everything's going good. And then at 6 months, boom. I don't know what's happened. This baby's never been sick. Now it's sick every day. You got a runny nose, right? If any of you had children, you definitely need that little nozzle suction thing. I don't know what they call that thing. Bulb, right? Oh, that thing would get so nasty sometimes. And you're just like, oh, do I clean it out or just throw it away? And then the one from the hospital was always better than the one you could buy at Walmart, all that good stuff, you know. Y'all hadn't had kids yet.
The nose Fritas and everything. I think I'm the only one in here that has Fritas.
You're the only one. Congratulations, you have
Thank
children.
you.
Helping the world population. So, but yes, that stuff, they'll just wake up and be all this. So you got to kind of let them, help them breathe, right? So you get that little thing, right in each nostril, and it just sucks it right in that bulb, and they can breathe. It's magic, right? Just a little story. Back to this. So we have that 6 months decline, right? Maternal antibody goes away. And then we're supposed to get levels of IgA and IgM growing during that time, okay? So they're very low at birth because they weren't maternally transferred through the placenta. So they got to start building up. So the concentrations of all immunoglobulins will start to rise as the infant begins to produce their own antibodies a few months of age, okay? So this definitely wouldn't be one you'd want to do right off the bat. My baby was, a week old. I want to know if their immunoglobulins are okay. We wouldn't know because moms are still there. All right, so around 1 year of age, the IgG is about 5 to 6 years. IgM reaches adult normal levels about one, the kid's 1, followed by IgG takes 5 to 6 years to get up to adult level, okay? In some normal children, IgA does not reach adult level until they're adolescent. So those are some things we need to keep in mind. And it's always helpful. I mean, I kept a little white blood cell count chart. I got it, I liked it because we posted it above our microscope. Because sometimes doctors, forget that a normal baby's white count is close to 19,000, right? Sometimes they panic. They're like, oh my gosh, they're almost at septic level of adult, right? Okay, but we know that mom's IgG, right, white count may be high. So sometimes we need to get those normal levels. So if you have an analyzer for CBCs, I know y'all been playing with one, right? Y'all get to play with the analyzer downstairs. And y'all went in the other room, got the analyzer, right? All right. So in our LIS, the lab information system, it would be very, very beneficial for reporting. We have an age level reference range. And then a lot of places just don't bother with that. They'll just say, that's too much trouble to put in reference ranges for white cell counts, red cell counts, and platelet counts, and all that for age or sex, right? Female, male, right? We don't want to report out a male's hemoglobin reference range for females. It's different, right? Slight, but it is different. We don't want to... And believe me, I hate to say this about doctors, but doctors go through your CBC report, and back when they had them on paper, because a lot of times they're electronic now, and they circle L's and H's. That's all they look for. That's the first thing they do. H, L, H, L. So if you give somebody an adult level or a kid, so we need to be better. We need to be better about putting that in. The systems are designed for that, so let's do that. So I don't know if Ms. Bednar has talked about that, but we need to get our reference ranges where they need to be. We don't need to be giving doctors reasons to circle H and L's when they're really not H and L's, okay? Leave you with that. All right. Here's our first one. Our first one, our predominantly an antibody deficient is X-linked Bruton's tyrosine kinase deficiency. I'm not going to ask you to get all involved in this one. I don't want you to like be an expert in Bruton's, but you can do a little something, you know. And I think your book gives you this PowerPoint, right? Gives you a little bit about it. Arrested maturation of the pre-B cell stage. So what Bruton's is it's X-linked first, right? They're going to ask you that on the board. Is Bruton's X-linked or is it autosomal recessive? You got to remember it's X-linked. So it's affecting who? Who's our patient that's being affected? Males. Okay, great. And they're not getting the B cell maturations. We know if B cells don't mature, what happens? We don't get to the plasma cell. We don't get to the immunoglobulin, right? We've got to have B cells mature. So the lack of the mature CD9 plus B cell in the blood and plasma cells in the lymphoid tissue, and we're going to treat this patient with gamma globulin. We're going to give them immunoglobulin. We'll give it to them, right? Because they're going to need it. Because they're going to be hypogammaglobulinemia. Are we good? So they have no plasma cells. They have some pre-Bs in their bone marrow. Since they lack B cells, their tonsils and adenoids are small. In entirely absence of lymph nodes, lack normal germinal centers. T cells are normal though, because it's not affecting their T cells. And about half of these patients have a family history of the syndrome. So where do we see? We see patients most commonly develop cynopulmonary infections caused by encapsulated organisms. Sorry again, Preston, but the rest of this class knows what that means. They know that encapsulated organism, such as strep, pneumo, right? Meningococcal, Haemophilus influenza. We talked about Haemophilus, right? Remember? Y'all grown Haemophilus influenza on the chocolate plate. Y'all looked at it, right? Didn't see it yesterday, but I didn't think y'all would be too upset if you didn't see Neisseria and Ghana and Haemophilus yesterday, were you? Okay. All right. Some patients have susceptibility to certain types of viral infections, including vaccine-associated poliomyelitis. Like a live virus vaccine should not be administered to the patient with X-linked Bruton's tyrosine kinase deficiency. A lot of good stuff. Common variable immunodeficiency is a heterogeneous group of disorders. This can be congenital or acquired. The symptoms begin at 20 to 30 years old. So it's a failure of the B cells to mature into plasma cells as a result of B cell or T helper cell defects. Again, treated with gamma globulin. The good thing is we have that. We have treatment. It would be pretty bad if we couldn't, right? So this is common variable immunodeficiency, and your book is called CVI. Prevalence, the prevalence is in 1 in about 25,000. Although it's low incidence, it does make CVI the most common primary immunodeficiency with severe clinical syndrome. Patients usually begin to have symptoms in their 20s to 30s, but the onset ranges from 7 to 71 age. So what we see this patient, he has a hypogammaglobulinemia. It leads to recurrent bacterial infections, especially sinusitis, pneumonia. About 20% of the patients develop herpes. Okay, zoster, that's shingles. Much higher incidence than in normal young adults. So all of a sudden you start to get shingles when you're 20 instead of 60. There's usually a deficiency in both IgA and IgG. Could also lead to gastric carcinomas and autoimmune disorders. The most common autoimmune manifestation of CVI are immune thrombocytopenia and autoimmune hemolytic anemia. All right, so you're my hematologist. This concludes Preston this time. Thrombocytopenia. Tell me what that is. Decrease in platelets. Yeah. How do we know we got a decrease in platelets? What is our go-to test for decrease in platelets? Y'all been doing them. Huh? Yeah. Well, I mean, I wouldn't rely on my counting of platelets on the slide. What else would I rely on?
Hematology analyzer?
Yeah, CBC. CBC, right? CBC, you're going to catch a lot of these just off some CBCs. All right. That's one of the tests that we're going to see at the end of the chapter that we're going to use mostly to determine whether it's like a pre-screen for everybody. We do CBCs on everybody. Okay. All right. Here's some more. We got transient hypogammaglobulinemia of infancy with normal numbers of B cells. Delayed development of the immunoglobulin production, especially IgG. Normal numbers of B cells, but the delay is in the maturation. So if we did a B cell count, lymphocyte B lymphocyte count on this patient, they would be pretty normal, but they're still not going into the maturation and leading to the plasma cell where we can get the antibody production. So this is shown early, 5 to 6 months of age. Okay, however, in some babies, the low levels persist for a longer time. So this is the 6 months, mom drops off, immunoglobulin, IgG drops off, and it's just not coming back up. Okay, they don't start synthesizing their immunoglobulins promptly. They experience severe pyogenic, sinopulmonary, and skin infections. What is pyogenic? Pyogenic.
Doesn't like to produce heat or light.
Fever. Okay, pyogenic, fever-producing infections. Not just a runny nose, but they got fever to go along with it. Pyogenic. All right, cell-mediated is normal, and there are normal levels of A and M, IgA and IgM, but IgG appears to be the most effective. Selective IgA deficiency. We just got through with IgA with our hypersensitivity reactions. We get low levels of IgA, perhaps of an impaired differentiation of IgA plasma cells. Patients may be asymptomatic or more susceptible to allergies, right? Autoimmunity. Y'all understand that one. We just came out of that chapter. IgG subclass deficiencies caused by mutations to the IgG heavy chain. CD154 deficiency. I'm sure all of you know your CD154, right? You do now, right? Probably hadn't heard of CD154 yet. Maybe what was the one CD we talked about? We've talked about several, but what's the main one? What is the pluripotent stem cell? What do we refer to that one as? Where all your hematology originates from.
Was it CD4 or CD8?
34.
No, you're thinking immunology. Go back to go to heme. Tell me which one of those CD cells needs help. It's where all of them start.
CD38 or 34.
34. There you go.
Really?
You got
That was our
34.
first
Yeah,
question.
34. Yay. We got that. All right, good. So 154 just going to be associated with who? Going to be associated with our primary immunodeficiency, PIDs, antibody linked. Decreased in all IgA, IgE. All right, we're gonna switch, we're into number 1 now, combined immunodeficiencies. This involves T cell deficiency. So we're switching from number 3, which was immunoglobulin, our antibodies. Now we're going to T cell deficiency. They're complex. It affects cell-mediated immunity, but if you're in the cell-mediated, we know it plays a role over here in humoral too. So here with combined immunodeficiencies, we have a possible treatment with bone marrow transplant. So we're getting very, very, not just treatment with immunoglobulins this time. We've got to change the whole course of the immune system. So a bone marrow transplant. We've got to reconstitute the immune function with combined immunodeficiencies. This one, severe combined immunodeficiency disease, SCID, is probably the most famous, even though it doesn't equate to the 50%. And SCID is, anybody know the other name for SCID? Been a couple of movies about it. One was a after school special. Y'all don't remember those, but we used to come home from school and they'd have a movie waiting on us at 3 o'clock on ABC. And they would show it and we'd all be out from school so we'd get to see it. And it'd be kind of like a short movie, be a TV movie. Had John Travolta in it. You don't know John Travolta, right? No? Okay. And it was about SCID, it was about severe combined immunodeficiency syndrome, and it was the boy in the bubble. Okay, so it's a movie about a boy who hadn't have an immune system, so he had to be bubble. So his whole house was a bubble. If you wanted to touch him, you had to go through gloves, right? Y'all don't remember? Never see that at all?
I've heard of it.
You've heard of it, Bubble Boy. Okay, this kind of got its name from that. It's a very, very serious primary immunodeficiency. All involve a defect in the normal T cell development. It may affect B and natural killer cell development. X-linked recessive, so a 2. Males, okay, caused by an IL-2RG gene mutation. Autosomal recessive form associated with various defects. But yes, that was our boy in the bubble. Severe, of course it was, he just decided at a certain age he was done living in the bubble and he was just going to take his chances of going out into the world. Yeah, it's real good. Then there was like a Pauly Shore version, I think, funny boy in the bubble movie later, probably before y'all's time too. Okay. But that's one that is actually a group of related diseases that we see with severe combined immunodeficiency. So this one affects not only the cell-mediated, but B cell can be both. So that's a bad one, number 1. So this would be in infancy, affect nearly any type of organism. We see yeast infections, pneumonia, diarrhea. Administration of live vaccines can cause severe illness. And we don't do very many live vaccines anymore. Okay, so don't worry about that as much as we used to. All right. So here's one of our names. Wiskott-Aldrich syndrome. It's very rare. This one is in the category 2. So this is a combined immunodeficiency with associated or syndromic features. Rare X-linked, so who's it affecting? Males, characterized by immunodeficiency, eczema, and thrombocytopenia again. Defective T cell function. Also decreased in immunoglobulin M. We have a decrease in A and G, but an increase in E. The defect is in CD43, an integral membrane protein needed to signal the transduction of the lymphocyte. Usually is usually lethal in childhood because infections, hemorrhaging, and malignancies occur. So without platelets, you got prolonged bleeding time. The bone marrow contains normal or somewhat increased numbers of megakaryocytes. There are abnormalities in both cellular and humoral ends of the immune system. So Wiskott-Aldrich syndrome. These are number 2, combined immunodeficiency. So you see this in the chart, table 19.2, you got reduced IgM and T cell defect, CD43 expression, usually in infancy, and then thrombocytopenia, eczema, and immunodeficiency. The other one is DeGeorge. DeGeorge anomaly, this is another category 2. So these are syndromes. So when you see syndromic features, so we call it, to me, it got a name, it's called a syndrome. Developmental abnormality in the 3rd and 4th pharyngeal pouches of the embryo. How many of you have had developmental, I took it, what was it, developmental, is it anatomy? Developmental anatomy, where you look at all the stages of the cell into the baby? Y'all done any of that? No? Okay. As the embryo is formed, we have an abnormality in the 3rd and 4th pharyngeal pouches. So everything that develops out of that pouch of the embryo is affected. So most patients have a deletion in chromosome 22. That important? Yes. That's how you're going to define DeGeorge. They'll say DeGeorge syndrome is defined as a deletion in chromosome 22. The results is underdevelopment of the thymus. So we know that, right? If we got an underdeveloped thymus, who are we going to miss out on? You're all supposed to say T cells, right? Yay. Hypoparathyroidism and hypocalcemia. So we have some cardiac abnormalities, mental retardation, abnormal facial features. So this is a big time developmental dysfunction, if you want to call it that, right? We're still in category 2. We have ataxia, telangiectasia, AT, rare autosomal recessive syndrome, ataxia. We think about muscles when we think about ataxia, involuntary muscle movements. Telangiectasia, capillary swelling, red blotches on the skin, low numbers of T cells, defective antibody response. We got this one, wouldn't think this one would show back up as much as DeGeorge or Wiskott, right, Aldrich, since they have great names and it's a little easier, but you never know. Ataxia may show back up. All right, so that takes us to defect in the phagocytic cell function. That's going to jump over to number 5. Okay, so what happened to number 4? Number 4 was diseases of the immune dysregulation. Many diseases with normal numbers of T and B cells reduced over their function. Don't see anything really big there, but if we did have a dysfunction, category 5 is these are congenital defects of the phagocytic number, function, or both, right? CGD is chronic granulomatous disease. Groups of disorders, inherited X-linked recessive or autosomal recessive. Neutrophils, since they're granulomatous, right, granulocytes, right, neutrophils unable to generate oxidative burst. Genetic defect component of NADPH oxidase system. I don't know where we are. I'd say Heather's probably up on NADPH because that's some of our chemistry, yeah, some of the things that we look at. This is kind of like the oxidation reduction system of the cell when you get out of the mitochondria, powering up the cell. NADPH is part of that system. So we have decreased killing of catalase organisms. So the organism can produce catalase, which y'all did some of that yesterday in lab, right? Did catalase test. See if the organism could do that. So neutrophils are unable to generate their oxidative burst. So their neutrophil is been changed, right? It's been a defect in it. So laboratory detection, we do nitro blue tetrazolium test or dihydropodamine test, DHR assay. I don't have either one of these, so I'm sorry. I don't have the nitro blue, the dihydroamine test for checking for chronic granulomatous disease. This one sounds familiar. So we're over in category 8, all right? So we're kind of moving through category 8, most inherited of the autosomal as autosomal recessive, meaning we have a deficiency in the early complement components. So we can associate this with lupus-like syndromes. C2 deficiency is the most common. C3 deficiencies associated with recurrent infections. We should know that because we don't have C3, we don't have phagocytosis, we don't get the bacteria taken care of. We also have late complement components. This is associated with Neisseria meningitidis. And we can have C1 esterase inhibitor, but complement deficiencies show up. So what do we do? So we're going to finish up the chapter. Give me just a minute. We're going to talk about how we do this. So this is how we would go about checking the patient for these illnesses, these immunodeficiencies. Patient history, right? And you're thinking, well, I never get to do a patient history, but you do have people you work with that do patient histories. So I always love going into a patient's room in the ER and I have no idea why they're there, right? Because they've only given a chief complaint. And then that's led to the orders of their lab work or their x-rays. And they haven't even done a history and a physical on them yet, right? They may be taking the temp when I walk in to draw their blood. That's how some ERs work. It's like, oh, let's get them in, get them out. We don't really have time for this patient history stuff. And they may learn a lot from that. So CBC, we're going to do a CBC on everybody that walks in the ER. Serum levels, IgG, IgM, IgA, IgG, we can do those. We can check our immunoglobulin levels. We have isohemoglutins. We can look for natural ABO antibodies. You're going to see that coming up with blood bank. Antibody response after a vaccine. Did we have a level response? Did we get protection against hepatitis B after our vaccine? Did I get protection against whatever I'm getting vaccinated against? We can do delayed hypersensitivity skin reactions to see if they can respond to skin tests. We had this one, we were going to do this one in our list of tests to do, was the CH50 assay for complement function. We just couldn't get it. They quit making it. Or where we were trying to get it, they didn't have it. I can't remember what it was. So we do a lot of testing. We can do confirmatory tests, immunophenotyping, flow cytometry to determine the numbers of our cells, B cell helper Ts. So we can actually measure those numbers of the individual cells. And you see that with flow cytometry on page 19.2. Here it is. Sorry, I had a picture of it. Didn't realize it. All right. These are just some other genetic testing. And one of the things that we can do is this. So newborn screening tests are very important. We do this on all infants born. We check blood, take their heel sticks. We actually take blood spots and we actually look for early detection of some of these disorders. If there's a whole list, okay, it's like 30 tests that are screened for at birth. All right. That's all I got for today. We'll see you downstairs. Those that need to help me with the wipes, thanks again for doing that. We'll stop the share, end the Zoom meeting.